Okay, so this is an 80-year-old man with a papule on the scalp, and we have a shave biopsy. And here it is down here. The stains that were done, so here, like I told you, I used SOX10. So we did SOX10, which was negative, P40, or you could use P63. Those, in my hands, are about equivalent. I think P40 is a little bit more crisp and clean, so I tend to like it better. But if you only have P63, that works totally fine. CK56, Desmond, and ERG are all negative here. So basically another one where we did this panel, everything's negative. So let's look at the findings here on this shave biopsy. So as a derm path and sarcoma pathologist, I see a lot of skin. Obviously, I see more skin than bone and soft tissue tumors just because skin biopsies are so much more common than bone and soft tissue. But I do see shave biopsies all the time. And so this is a relatively common specimen type. I just had a similar case to this last week, actually. So these come up pretty often. So here we've got an older person with a sun-damaged, what did I say? It was the scalp, is that right? And here are what we were looking at. The dermis is completely replaced by a proliferation of spindle cells. And when we go in closer to these spindle cells, we can see not good. These are ugly, pleomorphic nuclei. Look at that, bizarre, like a double eyeball looking at you. Really bizarre pleomorphism in these tumor cells. Some of them are kind of foamy and frothy. Other areas are more spindled and kind of fibroblastic looking with collagen deposition in the background. And then let me see if I can find where the mitotic figures were. Well, I should have marked it. There were multiple mitotic figures, including atypical forms in this case. I promise they're there. Let's see, maybe it's not on the bottom piece. So, all right. So go ahead while I'm looking for the mitosis that I should have. I promise I looked at these just the other day, but after looking at all of them, sometimes I do forget the certain area of the slide where the certain findings are. But what would you call this? How would you word this in your report? Look at that atypia. You could see that from outer space. I mean, that's so ugly and huge. Very bizarre. Or what would your differential diagnosis be before I told you about the immunostains? Well, how embarrassing. I can't find the mitosis now. But in any case, there were atypical mitotic figures in here and multiple mitotic figures. But with that degree of atypia, not surprising, right? And also, I will point out while we're thinking here, the epidermis is atrophic and has no squamous dysplasia. There's no squamous cell carcinoma in situ. There's no melanoma in situ over this. This is a purely dermal, pleomorphic, ugly spindle cell proliferation with mitotic activity in an old sun-damaged patient. Excellent. So we got the differential, which is absolutely correct. Spindle cell squamous cell carcinoma, spindle cell melanoma, atypical fibroxanthoma, also known as AFX, and its kind of deeper, more aggressive counterpart, pleomorphic dermal sarcoma, or PDS. And that's the main differential here. And you could also add in a few other things to that differential that are much more rare, but there are rare examples where you can have purely spindled angiosarcomas that don't have obvious vascular channel formation. I would say that the ones I've seen of those, and I've only seen it a few times, they tended to not have this dense collagen in the background, but because missing an angiosarcoma is a really serious problem, I regularly include a vascular marker in my workup of malignant spindle cell tumors in the skin. Just to make sure. And also I usually include the Desmond because there are rare times that you can get rhabdomyosarcomas in the skin, including in older adults. The oldest patient I've seen with a rhabdo in the skin was an alveolar rhabdo in an 80-year-old skin primary. And unfortunately, the patient passed away from their disease, and it was just a small skin lesion. So rhabdos can occur in the skin, and I co-authored a paper with Steve Billings and some other colleagues right back in the early days of my practice where I think ours is the largest series still of 11 cases of primary cutaneous rhabdo. So it's extremely rare, but what we found was some sarcomas, when they occur in the skin, they're much less aggressive than their bigger, deeper counterparts, but that's not the case with rhabdo. The rhabdos still are very aggressive when they occur in the skin, and many patients develop metastases and die from disease, unfortunately. So I do include a Desmond there to make sure. So in this case, what this is going to be either an atypical fibroxanthoma or a pleomorphic dermal sarcoma. Let me go back and show you the to talk about the panel of the stains here again. So here, let me explain. This is a panel that I use for these as other options. Again, if you don't, maybe you don't have socks in your lab. If you don't, I would recommend considering getting it. It is incredibly useful, especially if you evaluate skin at all. I find it much better than, say, MART1 for looking for melanoma in situ in patients with sun-damaged skin, because it's a nuclear marker. That's a topic for a different video or a different lecture. But SOX10, or you could use S100. They work both equally well. The one caveat to that is that S100 will stain scattered dendritic cells like Langerhans cells and other related cells in the dermis, particularly if you have ulceration or a lot of inflammation in a spindled skin tumor. You will see a lot of Langerhans cells in the background on S100. If you do a SOX, all of those will disappear. And I have seen people overcall things like that were AFX that had a lot of Langerhans cells in the background, call them as a spindle cell melanoma because of the robust background S100 positivity. So just know that if you see something and you're like, well, it's not diffuse strong S100, it's kind of patchy. If you add a SOX10 stain and all the staining disappears, then almost certainly what you were dealing with was background dendritic cells. And then P40 or P63 and CK56, or you can use pan-keratin. Different people have different views about how many keratins or if you should add P63 or P40 or not. I've found over time, at least in my current lab, that CK56 seems to work a little better than AE1, AE3, which is normally the keratin I use. But in the skin, I found that it seems the stain in our lab, at least, it seems to sometimes not work quite as well. And the CK5 seems to be a lot more crisp. And so I like that. And I've been using that more and more for spindle cell squame. And the reason I add P40 or P63 is that spindle squames sometimes lose expression of all keratins, but still tend to retain expression of P40 or P63. But if you just get a little focal kind of weak staining for those P40 or P63, I usually just disregard that. It should be really like nice, strong staining to make a diagnosis of spindled squame without any keratins, all right? And then again, Desmond I do for rhabdo, and also you can add in there that, leiomyosarcomas occur in the skin too, although usually in my experience, they really look like a leiomyosarcoma morphologically. I think it's pretty rare for them to be very bizarre pleomorphic when they're skin primary. And then ERG is the vascular marker that I usually like to use as a screen for angiosarcoma, and the reason for that is that ERG is very, very sensitive. I'm knocking on wood here, but I've not yet seen any vascular lesion that was ERG negative. Now, I'm sure if I keep doing this long enough, I'll run into one day. But so far, I've found that ERG, it will strongly and diffusely stain all the angiosarcs or other vascular tumors, benign and malignant, that I've ever tested it on. The thing to make sure you know about ERG is two things I want to tell you. Number one is, in the setting of AFX, you can have kind of patchy, weak to moderate staining in a subset of the cells. It's some sort of nonspecific reactivity, I just ignore that. I want to see staining that's as strong as the background blood vessels and is diffusely positive in basically all of the lesional cells. That's what I need to decide that something is diffusely positive for ERG, the way an angiosarcoma would be. And then the other thing I'll point out is that ERG is not specific for vascular tumors. It can stain a variety of other things. Prostate cancer stains for it. Some acute myeloid leukemias. You can also have it positive in about half of epithelioid sarcomas and others. So it's not a totally specific marker. So in any case, and I think here, actually, I should have pulled that up, but I do have right here, I have all of my videos and digital slides and some sample pathology reports all organized by entity here on Kiko at these two pages, this one for DermPath and this one right here for bone and soft tissue. So let me show you while we're here. I should have pulled this up to show you an example. Well, while that's pulling up, My internet's going a little slow here. I'm at home instead of at work. So I'll look up... So this is a case I learned a lot from. Also an old patient who had a solid atypical spindle cell lesion on the face. But it was a little bit more epithelioid than the case I just showed you. Very ugly cells again. A lot of mitosis, pretty plump. There's some vacuoles there. So this was seen by a really good derm path, and they sent it to me for a consult. I don't take consult cases anymore just because it was getting too busy, and I like being able to spend time with my daughters and my wife. But in the past I did, and so this came in, and this case is interesting because they had done the panel that I just showed you, and they had done a CD34 also, which was totally negative. And here I'll show you the stains. Here's the CD34. Totally negative here. Except for the background blood vessels, see? Tumor cells are dead negative, but look what happens when we do CD31. Diffuse, strong, blazing positivity. Oh, I'm really sorry about the internet. Strong, crisp staining for CD31 in the tumor cells. And look, for vascular stains, I want to see, this is a background vessel. Look at that staining intensity, the same in the tumor cells as it is in the background vessels. That's what I use as my internal control, as the background vessels. And here's what ERG looked like. Look at that. That's the kind of staining for ERG that I want to see if it's an angiosarcoma. If it's anything less than that, it's probably not an angiosarcoma in my experience. And so I do, on this little post here that I'm showing you right now, I actually do have a little write-up because this was a case of CD34 negative angiosarc, which is why I don't like CD34 as a screening marker for angiosarcoma, because I've seen a few cases that were completely negative for CD34, but I've never yet seen a negative, an ERG or 31 negative angiosarc. So I do have a little write-up right here. And again, you can just go to this page and look up angiosarcoma, and this case will pop up if you need to find this later. But this post right here talks through how I use vascular stains and what the pros and cons of the different stains are, and how I kind of approach them, how I use them in difficult cases. So you can come back to this if you like and check it out, okay? So back to our case there. Again, I got off on a tangent. I told you it would happen. There's just so many things to talk about, but I was like, oh, 3 hours will be plenty of time, but watch it. By the end, I'll be rushing to get through them all. It happens every single time. I apologize. Okay, so where were we there then? So this what I did is I did all of these. They're all negative, and then I've got this pleomorphic spindle cell tumor that is either an AFX or a pleomorphic dermal sarcoma. So the problem is I can't see how deep this lesion goes. Okay, so I've ruled out all the other mimics, but the problem is that AFX and pleomorphic dermal sarcoma, in my opinion, are the same tumor. We just give it a different name once it has aggressive features. The most important thing is if it invades the subcutis. Once there's invasion of the subcutis, some studies have shown that these tumors can behave more like a regular high-grade sarcoma with distant metastases and death from disease, whereas AFX, which looks very ugly and high-grade but is a small lesion confined to the dermis, that those tumors, when completely excised, have a very, very good prognosis and rarely ever metastasize or kill patients. So I don't think that they're really, in my view, I don't think they're two different tumors. They look the same, they stain the same. I think that we just make a different name when it has aggressive features and has a risk to behave worse. Now the problem is pleomorphic dermal sarcoma is a little confusing, right? Because the only time we really use that name is once the tumor leaves the dermis and invades down into the subcutis. But I don't make the names. I'm just trying to teach people about them. The other things is if you see perineural invasion, if the tumor is greater than, I think, 2 centimeters, And also if you see necrosis, all of those are things that you don't want to see in an atypical fibroxanthoma. And usually if I see those, I would call it pleomorphic dermal sarcoma. So in a case like this where it's transected, what I say as my top line diagnosis is pleomorphic spindle cell neoplasm, comma, atypical fibroxanthoma versus pleomorphic dermal sarcoma. I actually put the versus word right there in the diagnostic line and then see comment. That way they have to read the comment, right? So, and then in the comment, I explained that AFX and PDS look identical and stain identically. The only way we can tell is by seeing the bottom of the lesion and seeing how deep it goes. Wide excision is needed to get negative margins, and that we have to examine the excision specimen, or if Mohs surgery is used, that the debulk specimen that they take out needs to be saved and examined by either by the Mohs surgeons or sent for permanence. Because a lot of times, for basal cell carcinoma and squamous cell carcinoma in Mohs surgery, the debulk specimen is taken out and thrown away, basically, which sounds like blasphemy to pathologists, I know. But this is the way it's handled for things where the diagnosis is already obvious. But in cases where there's an uncertainty of the diagnosis or something unusual, I think it's a good idea to examine the debulk specimen for Mohs. So I usually include that on my note, and I will come back in the next week or two, and I will add links with answers in for all of these, and I will add in some sample pathology report links, so you can actually come back to this case later, and I'll have a link that shows you exactly how I word my comments and my microscopic description, and you're welcome to copy paste that and edit it to your liking and use it if you encounter similar cases in your practice. I've been saving sample pathology reports that I've been writing for the past 9 years of my career now, and I've got thousands of them. And my goal is, as I have a little bit more time in my practice now, I'm trying to slowly edit those and release them here on those two directory pages, the DermPath and the bone and soft tissue page, and put them there so that other pathologists can benefit from them and save themselves some time in how they word their reports. Because I found that in training I focused a lot on making the diagnosis, and in practice, yes, that's still really important, but I feel that there's a lot of times that it takes me a lot of time and effort just to figure out how do I word this and explain this complicated situation in a way that the surgeon or the dermatologist can understand. And so I imagine that maybe I'm not alone and that some of you guys have found that difficult too. And so that's why I thought, well, once I figure out a good way to say it, I might as well save that and I keep it in a big Word document, and then I'd love to share it with other people so they can benefit. So that's what I do in these. And if I see the whole lesion, if I get an excision and it's a small nodule in the dermis, then I'll just say atypical fibroxanthoma. Still needs to be completely excised, make sure that margins are negative, but the prognosis is excellent there. All right, and again, there's no specific positive stain for these. So I feel comfortable signing this out with this morphology and all of the pertinent stains to rule out the mimics of this, like spindled squame, spindled melanoma, spindled angiosarcoma, leiomyosarc, rhabdomyosarc. If I've ruled those out, then I feel fine to sign this out with H&E and a tray of negative pale blue immunostains. That makes some people really uncomfortable. They really want to have a positive stain. So if you do CD68 or CD10, a lot of people like to talk about CD10. CD10 usually does stain these, but it also stains, I've seen it stain spindled squames, melanomas, angiosarcomas, picomas, whole bunch of other stuff in the skin. So to me, CD10 is about as bad as Vimentin in the realm of spindle cell tumors. I have no right to comment on renal tumors or lymphomas or anything like that. Okay, so if you want it to turn brown, you can throw a CD10 on there. It'll turn brown usually. But you know what? If I did a CD10 and it was negative, I'd still end up calling it the same thing, AFX versus PDS. So that's why I don't do the stain, because the result is not going to change the way I sign it out. I was excited about CD10 when I started my fellowship with Dr. Weiss, because one of the papers had just come out just prior to that time talking about how it was a great marker to tell AFX apart from spindled squames and melanomas. And we tried it out a few times and it ended up being pretty rubbish, so we stopped using it. So in any case, those are my thoughts on that. All right, AFX versus pleomorphic dermal sarcoma. And I would say that the vast majority of these that I see are a transected shave biopsy like this, because they don't look specific clinically. They often look, this one's not ulcerated, but they're often ulcerated with a crust and scale on top. They look like a nasty squamous cell carcinoma clinically, or even a basal. So I feel like they almost always are shaved, just like a basal or a squame would be shaved, because the dermatologist sees it, and there's nothing special about it clinically that would indicate that we were dealing with something worse. And the reason I add that hedge about pleomorphic dermal sarcoma is that I've seen many times where the top shave looked like this. And then once it's excised, the tumor goes all the way through the subcutis down to the, the outer table of the skull, basically. And so on the shave, we're just getting the tip of the iceberg. So that's the real problem, is that I wouldn't call this, AFX margins positive. I want to make sure that they really clearly know, hey, this definitely could be a sarcoma. We just can't tell unless we can see down underneath it to see if it gets in the subcutis, to tell how deep it goes. So that's really important, because I have seen ones like that, and I've seen ones like that that did behave aggressively and had bad outcomes for the patient. Okay.